Thank you very much. I apologize for the problem the previous time, so if I could have under the title of Randomized Controlled Trials in Evaluating New Devices in Respiratory Monitoring, I'm going to address three separate questions. First question is, what is the role of randomized controlled trial in the assessment of respiratory monitoring techniques? Then, how should we evaluate monitoring techniques? And next, how should we introduce new technology? So, to address the role of RCTs in addressing respiratory monitoring techniques, it's helpful to step back and to look at the birth of the randomized controlled trial. Early American studies had shown that streptomycin was beneficial in tuberculosis, but the magnitude of the effect was unknown because the studies had been conducted in a haphazard manner. After the positive reports, American physicians were understandably reluctant to include a control group of patients who would not receive streptomycin. In 1946, both money and streptomycin were in short supply in post-World War II Britain. And on being appointed to the tuberculosis trial committee, Austin Bradford Hill resolved to make virtue out of necessity. He argued that streptomycin should be tested using a proper experimental design. And in a review he wrote just shortly before he died in 1991, he described the circumstances that led to the very first randomized controlled trial. He wrote, "We had exhausted all our supply of dollars in the war, and our treasury was adamant that we could have only a very small amount of streptomycin. That, I think, turned the scales. I could argue that in this situation it would not be immoral to make a trial. It would be immoral not to make a trial, since the opportunity would never arise again. Streptomycin would be synthesized and there would be plenty of it. We could have had enough of the new drug to use on only about 50 patients. And I thought that this was probably enough to get a reliable answer." Bradford Hill's design followed the approach recommended by Ronald Fisher in his highly influential text, The Design of Experiments. In the 1920s, Fisher worked at Rothamsted Agricultural Experimental Station in rural North London. At Rothamsted, Fisher investigated the effect of different manures on crop yields. It was here that Fisher developed his approach to experimental design that underpins much of today's medical research. At Rothamsted, Fisher demonstrated the power of randomization in experimental design. He argued that randomization could be used to avoid selection bias. So back to streptomycin. In 1947, patients were admitted into 3 London hospitals, and 55 patients received streptomycin for 4 months, and 52 were treated with bed rest. After 1 year, 22% of the patients given streptomycin had died, and 55% were markedly improved, whereas 46% of the control group had died. So the great appeal of the randomized controlled trial to clinicians is that it makes deliberate use of the experimental method for evaluating therapeutic agents. So with the introduction of the RCT, clinicians were able to obtain convincing scientific documentation of the benefit of a therapeutic agent rather than relying on the prestige and authority of an expert. The RCT is the ideal approach for evaluating a drug like activated protein C, Zegras. A single dose of this agent was supposed to work in all patients with sepsis without a requirement to adjust the dose depending on patient comorbidities. The RCT is an extraordinarily powerful tool for testing the effectiveness of drugs that are used without the need for individualized care, which involves multiple adjustments of dosing depending on a patient's response. It's ideal when addressing questions that lend themselves to a yes or no answer, to use or not to use streptomycin in tuberculosis, or to use or not to use Zegras in sepsis. Part of the power of the RCT in evaluating pharmacological compounds like streptomycin or Zegras is the sharp outcome, death or life. So how should we evaluate monitoring techniques? The first aspect of this question is the monitoring technique accurate? We answered this question by measuring bias and precision. How well does the new monitor fare against a reference standard? When pulse oximetry was introduced, several studies were undertaken to compare the accuracy of the pulse oximeter measurement of oxygen saturation against the reference standard. That is the direct measurement of arterial oxygen saturation in an arterial blood gas. Such bias and precision comparisons were first made under quiet resting conditions, and then under a variety of abnormal conditions such as low cardiac output, anemia, jaundice, vasoconstriction, hypoxemia, hyperthermia, and mechanical ventilation. From these studies, we learned the circumstances in which pulse oximetry was reliable and when it was not. The second aspect of the second question is, does the monitoring technique help me take care of patients? Simply connecting a patient to a ventilator does not necessarily decrease work of breathing. Instead, we need to carefully adjust the ventilator settings to achieve that goal, which is greatly aided by monitoring the configuration of the airway pressure contour on the ventilator screen. The third aspect of the second question is, does the monitoring technique decrease mortality? To some ICU physicians, this is the only important question. But there is more to science than the mere counting of tombstones. Mortality is too blunt an instrument when evaluating aspects of clinical management that involve a series of actions, each of which requires customized adjustment according to how a patient responds to the preceding step. Nobody would dream of undertaking an RCT to test whether monitoring of hematocrit decreases mortality in patients with gastrointestinal bleeding. Designing a protocol to cover all the contingencies that influenced expert care would be impossible. The fourth and perhaps the most vital aspect of the second question is, and that this is the part that's most underutilized, is to first conduct a thought experiment. This was the method used by Einstein to reach his most revolutionary discoveries when he worked as a clerk in the Berne Patent Office. So let us instantly do an extremely simple thought experiment. Will inserting a Swan-Ganz catheter into all patients in an ICU, including patients in whom there is not a good indication for its use, lower overall mortality? I suspect that all of you will answer no. A Swan-Ganz catheter will not lower mortality in such a setting. Indeed, it may increase mortality. Yet several RCTs have been carried out where investigators do not appear to have considered this thought experiment. Numerous factors, partially listed here, influence patient outcome in response to the use of a pulmonary artery catheter. So it's self-delusional to think that so many moment-to-moment steps based on individualized patient responses can be incorporated into the protocol of an RCT. Pulse oximetry is the most ubiquitous monitoring tool in a hospital. In 1993, Moeller et al. Published a landmark evaluation of this device. The investigators entered almost 21,000 surgical patients into a prospective, multi-centered RCT to determine the benefit of pulse oximetry during the perioperative period. In 1989, it was considered ethically acceptable to enroll perioperative patients into an RCT in which they would not be monitored with a pulse oximeter. Not surprisingly, detection of hypoxemia was 19-fold greater in the oximeter group than in the non-oximeter group. But there was not only no difference in mortality, there was also no difference in the rate of post-operative complications or duration of hospital stay between the oximeter and the control group. People commenting on this trial say that it was underpowered, despite the fact that it included almost 21,000 patients. But given the low incidence of perioperative complications, this has a certain valid point. But these and other interpretations miss the elephant in the room. The Moeller study was an impeccably conducted RCT, producing grade 1 evidence on the evidence-based medicine scale. The Moeller study had a clear answer. Pulse oximetry did not prove effective as a monitor during the perioperative period. If one hankers after grade 1 evidence, then logic demands that anesthesiologists and hospitals should stop wasting money on this ineffective gadget. But nobody followed that line of reasoning. Nobody recommended the removal of the pulse oximeter from the operating room and its environs. If the best anesthesiology brains continue to recommend perioperative use of pulse oximetry, one has to accept the corollary. The RCT failed in its ability to detect benefit. Rather than being a sharp, precise methodology, for the purposes of evaluating a monitoring tool like pulse oximetry, the RCT is a very blunt instrument. But there's a deeper message here. None of the Copenhagen researchers had conducted a thought experiment before embarking on this Herculean trial. Did anyone ask, if our RCT is negative, will anesthesiologists act on the results of our trial? Most people doing that thought experiment before the Moeller study would have answered no. Just like we teach our residents not to order a CT scan if the findings are not going to alter management. There is no reason to undertake an RCT of a monitoring tool if physicians are going to ignore a negative result. Here is a third example of the problems inherent in the use of an RCT to evaluate a monitoring tool in the ICU. Observing that the impact of including predictors in a weaning protocol had not been previously studied, Tanius undertook a randomized controlled trial to determine whether inclusion of the weaning predictor frequency divided by tidal volume, an index of rapid shallow breathing, whether the inclusion of this index in a weaning protocol would influence weaning time. They studied 304 patients, 153 in the protocol group, 151 in the non-protocol group. And in the protocol group, patients could proceed to a weaning trial if and only if they had an F/VT ratio of less than 106. In the second study arm, clinicians did not follow protocolized approach to weaning. The duration of weaning was longer in the protocol group than in the non-protocol group. The authors concluded that including a weaning predictor, F/VT, in a protocol prolonged weaning time. A fundamental problem with this study is that the authors assumed that physicians managing patients in the non-protocol group did not use the frequency to tidal volume ratio. But physicians are highly aware that frequency and tidal volume are key variables in deciding whether a patient will tolerate weaning and extubation. Once this knowledge has crept into a physician's brain, it cannot be surgically extirpated at the point of commencing a randomized controlled trial. To ensure that physicians did not employ breathing pattern in their decision analysis, as in this patient with a respiratory rate of 21 and a tidal volume of 491, while breathing on flow-by and thus likely to tolerate a T-tube trial, as opposed to this patient who has a respiratory rate of 37 and a tidal volume of 233 while breathing on a flow-by circuit and thus likely to fail a T-tube trial. Tanius et al. Would have had to take steps to hide or occlude the display of frequency and tidal volume on the bedside display and ventilator screen. A second problem is that F/VT was one component in a weaning protocol. It's important to make a distinction between the use of a protocol in conducting a research study and its use in everyday clinical practice. Patients who had an F/VT of 105 or less progressed to a weaning trial, whereas patients who had an F/VT of 106 or higher were returned to the ventilator. So when conducting a research, this is exactly how a protocol must be specified and followed. No flexibility is permitted in a research study. But a competent clinician would think it daft or silly to comply with a protocol that decided an entire day of ventilator management on a one-unit difference in a single measurement of F/VT. Such slavish obedience to a protocol is not how thoughtful physicians practice medicine. Rather, intelligent physicians customize knowledge to the particulars of each patient and are expected to outperform the inflexible application of a protocol. Only 1 of 7 RCTs free of internal validity flaws found protocolized weaning beneficial. Just as with the molar study of pulse oximetry, the RCT is too blunt an instrument to be able to capture changes in patient care that result from individualized adjustments based on repeated decisions made by a thoughtful physician. It's naive to think that a study of intelligent, iterative adjustments based on an ICU monitoring tool is similar to studying the effect of streptomycin. ICU researchers need to break out of the mindset that an RCT can be used to study all questions. Instead, study design is a matter of horses for courses. There never will be one single research design that is the right choice for every situation. The third question I'm addressing is, how should we introduce new technology? The answer is simple. Give every encouragement and necessary resource to creative individuals to do their thing, and then stand back. Of the 3 questions that I'm addressing, this last one is the most crucial, and the one where the current state of play is the most dismal or disappointing. Let us look at how the most successful monitoring tool, the pulse oximeter, was born. The development of oximeters was connected to the needs of the military aircraft during the Second World War. None of the planes had pressurized cockpits. So as a result, aviators lost consciousness during dogfights at high altitude, and they crashed their planes. It was judged easy to replace the aviators. It was the cost of replacing the airplanes that provided the main stimulus to monitor oxygen levels in the pilots. Much of the early work on oximetry was done in Germany. Kurt Kramer, working at the University of Göttingen, was a physiologist. And Karl Matthes, who was working at the University of Leipzig, and together they developed successful oximeters for use by the Luftwaffe. Working in Britain and America, Glenn Milliken developed an aviation air oxygen meter for which he coined the term oximeter. And it was only when the British and the American military found out that the Luftwaffe already had oximeters did they become interested in the device. With the discovery of the Clark electrode, which is still used to measure PO2, interest in non-invasive oximetry for measuring oxygen saturation dissipated or disappeared over the subsequent couple of decades. In 1972, Takeo Aoyagi, an electrical engineer in Neil Coton Company in Tokyo, stumbled serendipitously on the principle of pulse oximetry. Aoyagi was interested in measuring cardiac output non-invasively using the dye dilution method combined with a commercial ear oximeter. He found that noise caused by the pulse oximeter hindered him from making accurate extrapolations based on the dye curve. Aoyagi tried to cancel the pulsatile changes or the noise by balancing the red and infrared components of the signal. But the changes in oxygen saturation nullified his attempts to cancel the noise caused by the pulse. And then Aoyagi had his eureka moment. He realized that a ratio of ratios, the pulsatile changes in the red and infrared components of the signal, could be used to compute oxygen saturation. The crucial step in the discovery was the insight into the power of the ratio of ratios. In this equation, AC for alternating current symbolizes the pulsatile components, and DC for direct current symbolizes the non-pulsatile components of transmitted light. The ratio of AC red, or the pulsatile red component of the signal, over the DC red, or the non-pulsatile red component, divided by the AC infrared or pulsatile infrared over the DC infrared or non-pulsatile infrared, reflects oxygen saturation. So here is an example of how the discovery of pulse oximetry is a beautiful example of how one scientist's noise is another scientist's signal. The introduction of new technology into the ICU is completely dependent on creative insights like IOIB's recognition of the power contained in the ratio of ratios. Such creative thinking is the antithesis of the audit bean counting mentality involved in conducting an RCT. No number of RCTs will put a new monitor in your hand. By way of contrast with pulse oximetry, let us look at some functions we would like to be able to monitor in the ICU, but attempts to date have been unsuccessful. Pepe and Marini's discovery of autopy was another creative and important contribution. This report was based on recordings in 3 patients, and it perhaps is worth more than all the RCTs combined that have been performed on monitoring devices in the ICU. Autopeep is typically measured using an end expiration occlusion in a relaxed patient. But this technique does not permit continuous monitoring of autopeep. Instead, we need some continuous recording of end expiratory lung volume. Continuous recording of end expiratory lung volume is possible with Respiratory in the VC mode, but only over short periods of time and provided that there is no motion artifact. Theoretically, it's possible to use a pneumatograph to measure changes in the baseline of a tidal volume signal. But drift of the pneumatograph signal makes this impossible. A second much-needed monitoring tool is a pulse capnometer to be able to obtain real-time measures of arterial PCO2 in a manner similar to a pulse oximeter, which end-tidal CO2 fails to accomplish in patients with underlying lung disease. A third item on my wish list is to have a reliable and continuous measure of respiratory motor output. A fourth needed tool is to have a simple means of monitoring the major sensory inputs into the respiratory control system of the vagus, the mechanoreceptors, and so on. So in conclusion, to make substantial advances in monitoring of the critically ill patient, we need a fundamental reorientation of our thinking. We need greater emphasis on basic mechanisms, both in terms of machines and biology. We need to encourage and support dreamers who can conjure up innovative solutions to problems. And we need to place less emphasis on audit-style evaluation of monitors, such as the RCT, which is too blunt to even detect the power of pulse oximetry. Thank you.